طبعا غايبين كثير شكله، هلا راح يجيب جدول حضور وغياب. ها؟ جبته؟ بده يروح نسخة للعميد منه هذا الجدول. يلا لسه ستارت.
يعطيكم العافية. طيب بلش بالهايبوناتريميا. Hyponatremia is defined as a serum or plasma sodium concentration between less than 135 millimole per liter. Acute hyponatremia is defined as a fall in sodium over a period of less than 48 hours. طيب هلا في عندنا سودو هايبوناتريميا، عندنا يوفولوميك وعندنا هايبوفولوميك هايبوناتريميا وهايبوتونيك وهايبرتونيك. Pseudo hyponatremia, isotonic hyponatremia, which has classically been caused by severe elevations of plasma lipids or proteins. هلا بصير بفليم photometers measure the sodium concentration in whole plasma and assume that the plasma water concentration is 93% of the plasma. Since sodium is restricted to that, the plasma water concentration is since sodium is restricted to serum water, a marked increase in plasma lipids or plasma proteins essentially dilutes the sodium concentration as measured by flame photometry. طيب alternate methods used زي ion specific electrodes, they can only measure the concentration in aqueous portion of the plasma and will provide a more accurate measure. طيب pseudo hyponatremia is of no clinical relevance save the recognition of this phenomenon and avoiding unnecessary interventions that could potentially be harmful. طيب الهايبرتونيك hyponatremia
يعني سوري دكتور، nowadays the name is also changed. يعني ما عدناش حكينا بكتبنا pseudo. It is false hyponatremia and true hyponatremia. pseudo it was old name يعني.
الهايبرتونيك hyponatremia اللي هي بتصير بالextracellular plasma osmolarity is increased. Okay. Here the osmolarity of the extracellular space is increased, drawing water movement from the intracellular to the extracellular space. The increase in the aqueous fraction of plasma thereby lowers the serum sodium concentration, causing a true hyponatremia. الهايبوتونيك hyponatremia اللي هي بتصير extracellular plasma osmolarity is decreased، اللي بيطلع fluids يعني, and is the most common form encountered in clinical practice. This is primarily due to increased water intake or 87 impaired water excretion. Epidemiology, hyponatremia is the most common electrolyte abnormality among hospital inpatients and is present on admission in 15 to 30% of patients. When present, hyponatremia is an independent predictor of mortality, even at mildly reduced levels, both in short and long terms. As expected, the prevalence of hyponatremia is lower in the general ambulatory population, 22 to 5%, but is still associated with poor outcomes. طيب الايزوتونيك hyponatremia اللي هي بتكون pseudo hyponatremia from elevated false okay false hyponatremia from elevated lipids or proteins. Mannitol solution 5% used as an irrigant during surgical procedure. The solution is relatively isotonic but does not contain sodium, and thus hyponatremia occurs if large quantities are absorbed. الهايبرتونيك hyponatremia بيكون في hyperglycemia which lowers the sodium by 2.4 millimole per liter for every 100 milligram per deciliter. Increase بيصير بالplasma glucose. Osmotic diuresis can cause water loss which may ultimately result in converting the hyponatremia to hyponatremia. Intake of ethylene glycol, ethanol and methanol. الهايبوتونيك hyponatremia اللي بيكون يا low urine osmolality اما high urine osmolality. low urine osmolality بتكون primary polydipsia بيكون عندهم severe malnutrition and beer potomania. بالhigh urine osmolality volume excess, congestive heart failure ونفروتيك renal failure and cirrhosis. اليوفوليميا بتكون SIADH اللي هي syndrome of inappropriate ADH. بيجوا بhypothyroidism, adrenal insufficiency, glycine بيكون 1.5% or sorbitol 3% solution is used as an irrigant during the surgical procedure. As opposed to mannitol, these agents are hypotonic to plasma and thus hypotonic hyponatremia occurs when large volumes are absorbed. Reduction in serum sodium is often initially out of proportion to reduction in plasma osmolarity because of the fact that these agents are effective osmoles and facilitate water transfer from the intra to the extracellular space. However, glycine slowly diffuses into cells and sorbitol is rapidly metabolized, and thus plasma osmolarity will slowly decrease to the level expected by serum sodium. نروح على pathophysiology. As plasma sodium atomicity drops, cells in the brain must readjust intracellular osmolality by lowering the osmotic content. If changes occurs rapidly or in the face of severe hyponatremia, this adaptation fails, leading to cerebral edema, altered mental status, and seizures. Hyponatremia can be fatal should brainstem herniation result. Patients with underlying metabolic disorders such as cirrhosis or pre-existing neurologic disease, as well as children and young women, may be at a particular risk of severe complications without rapid reversal of acute hyponatremia. Central pontine myelinolysis osmotic demyelination is thought to be due to rapid correction of chronic hyponatremia. Alcoholic patients and those with severe malnutrition to be at particular risk for osmotic demyelination due to rapid sodium correction. عشان هيك بيعطوه على hours من milliliters. Cognitive, behavioral, and movement disorders due to occurrence of osmotic demyelination may not be apparent for days after the correction of hyponatremia, and visible changes on magnetic MRI scan may take weeks to appear. This does not appear to be a major concern in the correction of acute hyponatremia. طيب الريسك فاكتورز عندنا الكوموربيد كونديشنز زي congestive heart failure, cirrhosis, nephrotic, renal failure, SIADH والalcoholism. SIADH which is caused by malignancy. Medications impairing water excretion بنعطي thiazide diuretics والSIADH بنعطي antidepressants والantipsychotics. Volume depletions بنعطي اللي هم اللوب diuretics وpsychiatric illnesses اللي هم البوليدبسيا زي البوليدبسيا. Clinical presentations. It is usually asymptomatic until serum sodium is less than 125, but fatalities have been reported with an extremely rapid decrease from a normal sodium to the 120 to 128 millimole per liter range. Symptoms include CNS effects such as confusion, weakness, headache, seizures, obtundation with acute hyponatremia. Chronic hyponatremia developing over greater than 48 hours is generally fairly well tolerated. Symptoms include cognitive defects as well as nausea, vomiting, weakness, and headache. A thorough history should include the estimated duration of inciting factors and an assessment of signs or symptoms suggesting that immediate intervention may be necessary, such as the mental status change, lethargy, coma, and seizures. Management of patients with hyponatremia depends on whether the process is considered to be acute or chronic and the severity of symptoms. The physical exam should be geared toward assessing the volume status of the patient. Elevated blood pressure and S3 heart sound or the increase in GBP indicates volume excess, often in the setting of early CHF. Edema in the lower extremities or presacral region or evidence of pulmonary edema indicates an increased extracellular fluid in the heart failure and kidney disease. Conversely, orthostatic hypotension, decreased skin turgor, dry mucosal membranes, and decreased JVP suggest an intravascular volume depletion. Diagnostic testing, blood tests, renal function panel, plasma osmolarity, TSH, and cortisol levels. We should calculate the osmolar gap. The plasma osmolarity equals 2 times the sodium plus 1 over 2.8 plus glucose. Osmolar gap he measured minus the calculated plasma osmolarity. We should do urine tests, urine osmolarity, urine sodium, potassium, urine protein, and urine creatinine. In the imaging, بنعمل head CT if the patient has neurologic symptoms, chest X-ray to evaluate for any lung cancer. The diagnostic criteria عن plasma osmolarity, isotonic, hypotonic, and euvolumic. Isotonic زي ما حكينا false hyponatremia, confirm the hyponatremia via ion-specific electrodes. If unconfirmed, measure the plasma lipid and protein levels. Okay, mannitol, 5% review of medications will reveal likely etiology of hyponatremia is confirmed via ion-specific electrodes. Hypotonic examination of volume status, hypovolumic will have low urine sodium 100 milliosmol per kilogram, euvolumic SIADH, high urine sodium greater than 40 millimole per liter, and high urine osmolality. Euvolumic SIADH, high urine sodium greater than 40 millimoles per liter, and high urine osmolality. Primary polydipsia, beer potomania, low urine sodium less than 20 millimole, and low urine osmolality less than 100 milliosmol per kilogram. Clinical history will confirm this. Clinical history will confirm the studies. بالhypervolumic congestive heart failure physical exam راح يكون في increased JVP, S3 gallop, peripheral edema, and crackles on lung exam. Low urine sodium less than 20 millimole per liter, and high urine osmolality. In cirrhosis راح يكون عندنا ascites, peripheral edema, pulmonary erythema, caput medusae, spider angiomas, jaundice. Low urine sodium less than 20 millimole per liter. النفروتيك syndrome بيكون عندهم periorbital peripheral edema, low urine sodium and nephrotic range proteinuria بيكون greater than 3 grams أو greater than 3.5 over 24 hours. Hypertonic toxic ingestions, elevated osmolar gap greater than 10 milliosmoles, elevated anion gap greater than 12, acidosis, measurement of toxic compound is definitive diagnosis. Hyperglycemia, no osmolar gap as glucose is included in the calculated plasma osmolarity. Hyperglycemia will obviously be present. Treatment of the chronic asymptomatic hyponatremia. Chronic hyponatremia without an acute neuropathic event is best treated by fluid restriction. Experts have suggested that examining the urinary electrolyte content will aid in determining the degree of fluid restriction. The ratio of urine sodium plus urine potassium over plasma sodium can be used as a guide. No free water, و.5 ل 1 بكون 500 ملي و.5 بكون 1000. If the ratio is greater than 1, the patient is excreting no electrolyte free water and any water ingested will be retained. Withholding free water will allow concentration of serum sodium to rise via an insensible water losses. If the patient produces 2,000 milliliters of urine that day, 1,200 milliliters will be electrolyte-free water. Restricting fluid intake to 1,000 milliliter will result in a net of 1,000 milliliter minus 1200 زائد 800. Accordingly, above the recommendations should be adjusted to the patient's urine output. These recommendations also assume that the urinary electrolyte loss is matched by dietary intake. Chronic treatment of SIADH seldom requires pharmacological agents, and these are usually reserved for cases resistant to the above interventions. Lithium will demeclocycline both induce nephrogenic diabetes insipidus and have been used to treat SIADH. Oral urea is another safe alternative for case of refractory SIADH. Palatability is probably its biggest drawback, but doses of 30 to 60 grams per day reportedly are effective in managing the SIADH. Acute and or symptomatic hyponatremia. Hyponatremia, acute or chronic, presenting with significant symptoms may necessitate emergent therapy with hypertonic saline. Loop diuretics are often used in tandem to aid in free water excretion by lowering the urine osmolality and to prevent the volume overload. Severe CNS symptoms due to hyponatremia usually respond to very modest increase in the serum sodium, often a less than 5% increase in presenting value. Once symptoms have been controlled, the rate of correction is adjusted to no more than a total of 8 millimole per liter in the first 24 hours, including the initial rapid correction. Over the next 24 hours, sodium correction should probably not exceed an additional 10 millimole per liter. More rapid correction increases the risk of osmotic demyelination, as we said previously, especially in chronic hyponatremia. Serum sodium should be checked frequently every 1 to 2 hours to avoid the overcorrection of sodium. The human body is not a closed system, and one must take into account urinary losses of electrolytes and an insensible water losses when calculating the replacement strategies. Potassium replacement can increase the serum sodium concentration and may result in overcorrection. Example, a 70 kilogram male with SIADH and the sodium concentration of 110 millimole per liter with mild mental status changes. Urine sodium is 100 millimole per liter, urine potassium is 71 millimole per liter. Assume that changes are due to water gain. Calculate the TBW, the total body weight. Initially with normal serum sodium, total body weight for a male is 60% of the body weight in kilograms. In this case, it is 42 liters. After loop diuretics such as furosemide, the urine is usually hypotonic to plasma and is roughly half normal saline in content. Thus, the sodium in 1 liter of normal saline given after furosemide would therefore be excreted in 2 liters of urine, creating a net loss of 1 liter of free water. However, monitoring urine output and urine electrolyte is crucial because many have more than one reason for hyponatremia: concomitant volume depletion, and hypertonic saline may suppress the ADH release, leading to a prompt aquaresis. If not accounted for, these equations may markedly overestimate the degree of correction. يعطيكم العافية.
شكرا دكتور. حطنا على الهايبرنتريميا. دكتورة، لا اللي فوقيكو، اللي بجنبك.